Very good evening and welcome all to this session. I am Arpita from Clarinet. Clarinet is very proud to be a part of this webinar as a digital partner. Now I would like to play a short video of Clarinet. Thank you. Thank you all for your patience. Clarinet is India's largest live digital CME and doctors-generated medical content platform. Our website is www.clarinet.com. Now, without doing further delay, I would like to hand over the session to Dr. Anjali Pingle, ma'am. Over to you, ma'am.
Good evening, everybody. Thank you for joining us. And today we're going to discuss prehabilitation. Our speaker is Dr. Nishkarsh Gupta. I just wanted to introduce our next topic as well. So on the 12th in the evening at 6 to 7 p.m., Dr. Devatya is going to speak on how to review a journal article. I just wanted to warn you in advance. And today we're going to deal with prehabilitation and how to use CPET in an onco patient. With this, I would like to hand over to Dr. Sohan Solanki, who's our chairperson for today. You know him very well. He's our secretary. Over to you, Dr. Solanki.
Hello. Hello. Yeah. Hi. Thank you very much, Dr. Anjali. And welcome all to this SOPSI webinar series. And I'm Dr. Sohan Solanki. And so today we have this lecture on like role of rehabilitation in oncosurgery and like role of CPET and so many other that we have like pathways. So Dr. Nishkarsh Gupta, he is a professor in AIIMS Delhi and he will be speaking on this topic today. So I think he is on the way and he'll be there in 2 to 3 minutes from right now. So we can just we had to wait because he was somewhere in the traffic in Delhi. So hopefully he'll be there in 2 to 3 minutes. So meanwhile, we can just, if anybody have you, any of you are like practicing some prehabilitation, some other form of prehabilitation side like nutritional prehabilitation or a physical prehabilitation or anemia correction or anything you are practicing, anybody can, they can like either write on the chat box or Dr. Anjali, what do you practice in your hospital?
I don't think we are very big on that. I was just wondering whether you have any experiences with CPET because you guys have a CPET unit, right?
Yeah, so CPET we have, but this CPET is not in our department per se. We have a CPET machine with our internal medicine department, and we send our patient for the internal medicine department. But CPET, yeah, but that we are doing CPET, and CPET is having a good role because it will tell you everything from the from cardiac point of view or from the pulmonary point of view, also from the metabolic point of view. So a complete package you can see like cardiopulmonary and metabolic things you can like have it. And another and role of CPET is nowadays increasing. So because more and more like there's some frail patient, not in frail patient. The CPET is only on those patients who can perform some type of exercise like some cycling and all that. But more and more the like high risk patients we are getting for.
Yeah, I think yeah, your definition is widening.
Yeah?
Your definition is widening, no?
Yeah. So definition is because now we are getting more and more high risk patients and doing a CPET and seeing like what patients is having like what is his or the lung function, how is the cardiac wise, what is the metabolic function in the body. So they will tell you everything, and you can like only one test can tell you so many things. We don't need a separate cardiac test or a separate like PFT or something like that. But it will be a good thing to go CPET. But it's not available everywhere, and it is
it's something of great interest to everyone because not all of us have seen it.
And if the patient is like a frail patient, and then he will not be able to perform the cycling and all these things. So
So I think Dr. Swapnil Parab was telling me the other day that the definitions for using for going in for surgery are widened quite a bit with the use of CPET. And those patients have actually performed well after surgery. So it is a valuable test and it really does give us good results.
Yeah.
So I think.
And this prehab is not only CPET, prehab is like this nutritional, prehab is also very important. The patient should be nutritionally as and close to a physiological things. Like if you improve the patient neurological, well, not only the albumin, but also the globulin. So like if there is any albumin globulin reversal, that needs to be very corrected. Patients should, if the patient is anemic, this will also correct some form of anemia. Although there is not really great evidence to show the benefit, but yeah, but if we correct anemia, it will definitely help also into the some form of physical rehabilitation also. It will improve because after many patients after correction anemia, they are physically better than the before anemia correction also.
Yeah, actually anemia is an independent predictor of mortality after major surgery. So I think correcting anemia is one factor which would definitely give us much better outcomes. And
so we are waiting for Nishkarsh, and Nishkarsh is still not here. So but he'll there because I just had a word with him and he'll be in there in 2-3 minutes. He told me. So anybody else like any comment you can write on chat box and we can just discuss.
Does Swapnil want to add anything at all?
Madam, I'm driving right now.
Okay,
so
no worries. Yeah.
Safe to talk right now. But yes, the CPET is definitely useful in, especially in thoracic surgery when we have sort of, when we rely on PPO values, the post-operative pulmonary functions. And when they fall in a dangerously low levels, but you don't have any prohibitive other factors which will deny the surgery to the patient. In such patients, to evaluate the cardiopulmonary system in a unique way, I think the CPET helps definitely there in there.
Okay, so it has a valid role in thoracic surgery.
So do you do the physical prehabilitation or the pulmonary prehabilitation in your hospital?
We do to some extent, but it is all very individualized as far as the surgeons are concerned. But they definitely go in for pulmonary prehabilitation. But we do not have a CPET unit. I think only AIMS and Tata have it, if I'm not wrong. I'm not sure whether TMC Kolkata also possesses a CPET unit.
So we as our all patients, they go for the pulmonary rehabilitation definitely without fail. So the physical and the pulmonary rehabilitation and also this nutritional rehabilitation is like part of our routine care. So we send all the patients for the nutritional assessment. So the nutritionist assess their nutritional status, and then according to their like deficit or like non-deficit, he will advise like some other form of some supplement before surgery. And as we like we all have like some form of the waiting list before surgery. So there is some like 2 to 3 weeks of wait time is there for every surgery. So we can utilize that waiting period to improve.
Yeah, I think that is where there is a slight,
Like if you have some time waiting period, you can actually utilize that period to make a patient better for the surgery. And all these prehabilitation, they like improve the outcome because the patient like get out of ICU or the recovery earlier than the patient if you are not undergone any prehabilitation part of the.
What happens is in the private practice, mostly patients are well nourished and there's not a lag time, not a waiting period that is significant. So unless that is specifically indicated, we don't really go in for nutritional prehab. Pulmonary prehab, yes. Should we call up Dr. Nishkarsh and see if, shall I call him up?
Yeah, please call because I will.
Yeah.
I would request everyone who have joined for the session to please be patient. The speaker will be joining soon, and we shall resume with the session. Thank you all for joining in. We are resuming the session soon. I think sir is busy in an emergency case. So that is why it's taking him for a while to join for the session. Let us join and we shall start with the session once again. Dr. Gupta has joined.
Yeah, I think there is some complaint from our audience that nothing is. Oh shit! So
good afternoon.
Oh, Nishkarsh has joined. Excellent. There is a
Yes.
comment that we cannot hear anything in the SOAPC group, so transmission is intermittent. Can we just amend that?
So good evening, Dr. Nishkarsh.
Extremely sorry, but got stuck on the traffic. Sometimes, the literacy can be bad.
Even I'm on the way back from hospital. So it's okay. They are busy life everywhere. So we all understand that that traffic is not in our hand. So good evening, everybody. So I introduced Dr. Nishkarsh. He's a professor in Department of Oncology and Palliative Medicine in AIMS New Delhi. And he will be speaking on this topic of prehabilitation today in this webinar series. So I invite Dr. Nishkarsh. Without delay, please start. Thank you very much.
Thank you, Sohan, for the kind invite and introduction. So I'll be speaking on prehabilitation and a bit of CPET. So this is the overview. My slides are visible and my voice is clear?
Yes, sir.
Okay. So I'll be basically covering what is prehabilitation, how it is different from rehabilitation, what are the goals, what are the specific interventions as anesthetist we can do, when and what to start, and what are the outcomes and some future directions for use as anesthetist. So broadly speaking, prehabilitation is something which are basically some interventions which we can do before surgery, and they're likely to improve patient outcomes. So it is a process of cancer continuum of care that occurs between when the patient is diagnosed with cancer and patient is started for some treatment, and it includes psychological, physical assessments that will establish baseline function as well as identify impairments and provide interventions. So basically there's some interventions which may be psychological, physical, which will overall help to improve the outcome of the patient. Now, how it is different from rehabilitation? So rehabilitation is healthcare services that help a person get back or improve skills. So basically once the surgery is done, once the intervention is done, then a lot of interventions are done to overall improve the functioning for daily living, which may be hampered because of the procedure which is done. While in prehabilitation, it is time-based and includes only those assessments and interventions that we start before the acute management for cancer treatment is done to improve outcomes. So this is done before the procedure, and essentially rehab is done after the procedure. So now broadly, if we talk about preoperative period and prehabilitation, we know patients are in a better physical condition. There can be some waiting time before surgery, say between 2 to 4 weeks, which is a golden period for us to utilize. And whatever we teach in the pre-op, it has to be continued in the post-op. So the patient is in a better frame of mind, the compliance is likely to be better, and we can involve family and caregivers in it, so that overall, whatever we suggest is kind of taken care of by the patient and they do it more diligently. Whereas in the post-operative period, we know patient might have fatigue, they may be anxious, then they may be concerned about the scar, the healing process, and also they may await an additional treatment. So it is a more complicated process, and that is a reason that rehabilitation probably doesn't work as good. So now we can see that, just a minute, I'll have a pointer. Okay. So we have a prehabilitation in the preoperative phase. Once the cancer is diagnosed, is posted for surgery. So we have about, say, 2 to 3 weeks, during which we have a prehabilitation, components of ERAS, and then when the surgery is done and the patient is planned for next kind of intervention. So usually cancer treatment is a combination of a surgery, radiotherapy, and or chemotherapy. So whatever is planned, so that is a post-operative phase after the surgery, say usually about 4 to 6 weeks. So that part is a rehabilitation part. So now this was a randomized controlled trial in anesthesiology published in 2014. And they found the difference between baseline and 8-week 6-minute walking test was significantly higher in prehabilitation compared with rehabilitation group. And higher proportion of prehabilitation group were also recovered to the baseline exercise capacity at 8 weeks. So basically, considering the patients are in a better frame of mind, they're likely to comply better. So outcomes are much, much better as compared to rehabilitation. So why do we basically need prehabilitation? So we know that mortality rates with major cancer surgeries can be as high as up to 10%. In addition, there can be tissue trauma, decreased physical activity. There can be starvation for a period depending on the surgery. Usually nowadays we say 2 to 4 hours, 2 hours before we can give clear fluids, but still starvation might still be there. Then, or the patient has been on, because of colorectal malignancy, they are not having enough, so they are usually in a poor nutritional state. There is a psychological stress and the age factor. So there can be a rapid decline of functional capacity, recovery is slowed, and there can be increased post-operative complications. So specifically talking about cancer patients, the challenges can be malnourishment and associated cachexia, the systemic effects of chemoradiotherapy if the patient has received prior to surgery, and patient might be having pain and some other medication which might affect the overall outcomes. Coming to chemotherapy. So all of us know neoadjuvant chemotherapy is a common modality in this patient, and patients do receive chemotherapy before being posted for surgery. And depending on the treatment given to the patient, there can be a pulmonary toxicity, cardiotoxicity, hepatotoxicity, and nephrotoxicity. These are the things which patient might be having. So we have to be careful in the preoperative period and need to optimize as per the need. Now, basis of prehabilitation is that patients with malignancy often receive this adjuvant therapy, and which, if administered before the surgery, may require 6 to 12 weeks of recovery. So if patient is posted, it was a disease which was more to begin with, so they decide to give a neoadjuvant chemotherapy. So after 6 to 12 weeks, they will go for a surgery. So in this window, we can train the patients to have a better outcome after the surgery. Or if patient is for upfront surgery, still you may have up to 2 weeks, and we can utilize that for overall outcome, improved outcome of the patient. So coming to the components. So prehabilitation basically includes functional outcomes, basically exercise prescription, medical optimization, nutrition, which is usually a dietary modification, stress management, the relaxation strategies, and lifestyle choices like a cessation of smoking, alcohol, good sleep hygiene. So all these things are 4 components of prehabilitation. So broadly, as anesthetists, we are supposed to do a best possible medical optimization. It is unlikely that we make the patient ASA grade 1, but yes, we can do good interventions to reduce the risk of the patient. Structured preoperative exercise program. So structured is a good important word. So we cannot do any exercise, but it has to be structured as per the need of the patient. We can give hematinics to improve overall anemic condition and reduce the perioperative blood requirement. Nutritional support to improve overall nutrition status. Psychological support to reduce anxiety. And things like smoking, alcohol cessation have a good outcome in the post-op period. Now it is a multimodal approach. So preoperative period, especially in cancer surgeries, will involve a multidisciplinary team. In addition to anesthesiologists, there are surgeons who will be planning the surgery, then perioperative physicians, if there's an elderly patient, there are geriatricians, and most important team members, the allied health workers, dietitians, physiotherapists, and psychologists. So they will help us to overall stratify the risk and formulate a focused multimodal prehabilitation program. Now, another important thing is when to start. Now, ideally, the patient should be introduced to the prehabilitation program on the first visit. So once the patient is diagnosed with a malignancy and is planned for a surgery, so that is the ideal time to introduce, because we should not waste even a single day, and patient should be put on customized prehabilitation program. We need to explain various steps of the program and record the baseline anthropometric measurements, which are weight, height, lean body mass, and body weight. Then the multidisciplinary team I talked about, physiotherapists, nutritionists, psychologists, have to assess the patient to ascertain the body strength, nutritional status, and the mood. And then another important thing is this prehabilitation program should be home-based program over 4 to 5 weeks ideally before surgery, which can be continued after surgery. So home-based is an important word because we cannot expect a patient to come every day to the hospital. So initial training at the hospital followed by home-based program with mentoring and monitoring is the key, and that should be done. Now coming to medical optimization. Now problems of unoptimized patient are delayed recovery, problems with the psychology and behavior. They can be increased post-operative complications, increased hospital and ICU stay, overall increased cost and mortality. So all these things are risk factors of unoptimized patient. So optimization for hypertension, diabetes, COPD, anemia, and many other diseases is important. And cessation of smoking and alcohol are easy things to do. And believe me, they are the best time in the perioperative period that we should counsel them. And they're likely to stop these if done in time. So nicotine, as we know, has sympathomimetic properties, increases the oxygen demand. It may lead to vasoconstriction, reduce the blood flow to various organs, increase mucus production, and impairs bronchial ciliary function. Whereas alcohol, more than 60 grams per day, may lead to immunosuppression, cardiopulmonary insufficiency, hemostatic imbalance, and increased surgical stress response. So alcohol abstinence and smoking abstinence, we can see. So best will be up to 6 to 8 weeks. We can have maximum effect, but even 2 to 4 weeks of difference of stopping or abstinence from alcohol and smoking may improve wound healing, immune competence, and overall endocrine stress response and hemostasis. So whatever time we stop is good. So it is a good idea to counsel the patient and stop them in the pre-op period. Now, another important question which we may be troubling us is, do we have enough time? So can we actually start rehabilitation in a patient who is malignant? We know it may increase over a period of time. And are we ethically sound that we start rehabilitation and wait for some time before taking for surgery? Now, this is an important slide. So this is an acceptable waiting time for cancer surgeries. So we can easily see that there is a very few malignancies which have an immediate need for attention or surgery, like those having airway obstruction, hemorrhage, and neurological compromise. And most of them are kind of emergency procedures, and for those, we definitely cannot wait. However, most common malignancies which we face in day-to-day life, we have about 14 to 28 days before which they can be taken for surgery. So that is a good window of opportunity for us to work on and improve patients' outcome. So from onset of symptoms to visit to surgeon to surgical workup, then we have a decision to operate and surgery is done. So that from surgical workup to surgery done, we have total preoperative time for about T1 plus T2. So this is usually 14 days minimum in a busy center. And that is the time I am talking about. Now coming to structured preoperative exercise programs. So we know we have a patient who is a malignancy, associated age-related sarcopenia, medical comorbidities we discussed in the previous slide. Then in addition, because of all these, patients are usually sedentary. There's a fatigue which because of malignancy. And on top of this patient, we add on surgery, radiotherapy, and chemotherapy. So all these things together lead to a deconditioned patient, which may have a difficult recovery if any procedure is done. Now coming to structured preoperative exercise programs, it involves regular physical activity that is incorporated into a planned and structured program. So it includes cardiovascular or muscular fitness, targeted exercise which focus on training specific muscles. So idea is to increase lean body mass to body fat ratio, decrease insulin resistance, alter the prostaglandin synthesis, and overall increase skeletal muscle adaptation. Now, once we ask the patient to exercise as per the need, we need to measure the intensity of the exercise. So we have a Bogue scale. So we can see the 6 means no exertion at all and 20 is maximal exertion. And we also measure the heart rate. So heart rate is moderate intensity should be 40 to 60% of age predicted maximum heart rate, and vigorous should be 60 to 85. Similarly, Bogue scale provides subjective meaning of estimating individual heart rate and a perceived exertion of 11 to 16. So light to hard is a moderate intensity which we are looking at. We don't want to strain to the maximal exertion, and we should not advise exercise which is not causing exertion at all. So somewhere in between is the key, and that needs to be done. In addition, we should be monitoring the heart rate. Now, adherence to pre-op exercise programs has been variedly reported to be 16 to 97%. So the important thing is what are the emotional and personalized programs we are offering, because mostly what happens is we advise the patients the program, but we do not follow them. There is no mentoring online or offline. The patients are not called intermittently, and so they tend to do for 1 or 2 days and they tend to forget. So it is important to have a constant monitoring of these patients. And moreover, to reduce interruptions and improve compliance, we have to have set daily targets, which may be step, distance, or energy expenditure, whatever we may do. We should have a regular feedback. We need to tailor as per the need and the possibility of doing it by the patient, and a continuous follow and supervised training session in the hospital. So nowadays, in an era of technology, we have so many things to monitor. So we have apps, we have gadgets, which can be used to benefit of the patient. The important thing here is it has to be constantly monitored so that we achieve our target. Now, there's something called 6-minute walk test, which can be also used to assess the patient fitness. And in addition, it can be used to guide training program of the patient. So what we do is a patient has to walk the longest distance possible in a set interval of 6 minutes through a walking course, usually a straight 30-minute long corridor. And the longest distance walk during 6-minute walk is shown to have a medium to high correlation with the actual VO2 measured at the peak of exercise in the CPET machine or the cardiopulmonary exercise testing machine. So this is an important easy test we can do bedside. We need not have expensive equipment. And even without them, we can still assess the patient fitness and see the improvement in fitness over a time by our exercise intervention, which we do. So there are calculators also. What you can do is you can select the gender, height, age, and weight, add the distance traveled. And what it will show is, it will show what is expected and what is the percentage we expected and what is the lower limit of normal. So all these things you can get on click of the mouse, but you must know how the test is to be done and you must measure the distance walked accurately. Now we have CPET guided training programs also. So we have exercise protocols during CPET. Now CPET is a machine which is assessing your cardiac and respiratory parameters at the same time. So as anesthesiologists, we know in isolation, respiratory and cardiac system is not as important as if they are working together in tandem because they compensate for each other. So this is a kind of a good device which you are able to assess the both functions in a dynamic situation. It evaluates the response of exercise across entire range of functional capacity. It will allow for assessment of normalcy or otherwise the exercise response, identify the size, the functional exercise limitation cause. It will also give an appropriate frame of reference training. So once we identify the causes, we know what needs to be improved and reference training can be done. And we can also, there can be a short duration of high intensity exercises if required. So CPET guided training program can be delivered 3 times a week for 6 weeks. and it may help in overall improvement of the patient in the post intervention phase. It also known to increase the anaerobic threshold and maximum oxygen consumption if done properly. Now, what is the optimal duration? So less than 4 weeks of prehabilitation may not be sufficient, mostly to reach preoperative fitness targets, but more than 3 months will be having a compliance issues. So effectiveness and compliance, we have to trade off between the two balance. And also we have to answer this question, which is important. Can surgery be postponed for that much more time? So there is no optimal duration for all patients. So it will depend upon the type of surgery, the complexity of surgery, how urgent is the surgery, and how much time we have. But important thing is whatever time we have, say about 2 weeks, 4 weeks, 6 weeks, that has to be utilized for maximum benefit of the patient. Now, this was a systematic review published in Surgical Oncology, which basically explored the pre-surgical exercise intervention in cancer patients. And it's showed that pre-surgical exercise interventions, they had a potential to improve patient outcomes, and they should be done routinely. Now, another component of prehabilitation is hematinic optimization. We know that anemia is quite common in cancer patients. This may be because of a lot of reasons, including malignancy itself. So blood transfusion, we know we should not do because it may increase cancer recurrence and mortality, and we should be really careful when we're transfusing blood in these patients. So the overall idea is that we need to optimize the oxygen carrying capacity of the patient by addressing anemia or iron deficiency, which may lead to increase in anaerobic threshold and VO2 peak. So transfusion of the blood has been shown to have improvement. So we can do that. But we have time. It is better that we give intravenous iron, which has been shown to improve overall iron stores and overall increase in hemoglobin over a period of time. The role of erythropoiesis stimulating agents is limited and should be avoided. So indication is if hemoglobin is less than 10 gram%, then we can give ferric carboxymaltose, which is the most favored one, IV preparation, because oral preparation either patient may not tolerate, absorption is an issue, and then considering we have time is limited, so it doesn't usually work. So it is always best to give a IV preparation of iron. So it is most rapid and complete depletion of iron stores. However, in a recent Cochrane review, could not demonstrate a statistically significant benefit of iron therapy for treatment of anemia because the randomized trials were limited. Coming to nutrition optimization, prevalence of malnutrition is up to 60%. It may be due to tumor-induced metabolic abnormality, inadequate intake. So if their patient has GI malignancy, we know patient is not able to have because of diarrhea, obstruction, nausea, so a lot of issues. They can be metabolic and inflammatory causes. And drugs which we may give to these patients may lead to an anorexia and derangement in the GI system, which itself lead to malnutrition. So the effects of malnutrition are increased risk of postoperative complications, poor wound healing, prolonged length of hospital stay, delayed recovery, higher rates of readmission, and increased postoperative death. So we need to address the nutritional deficit these patients might have. So overall goal is to improve energy intake, increase appetite, decrease incidence, and achieve anabolism, and overall integrate nutrition with the exercise. So we have to balance the exercise program with the improved nutritional intake so that patient is able to sustain the exercise also. Well, albumin, we say should be more than 3, but we do not wait that we start the nutritional program, we improve the protein intake, we improve the overall nutritional intake, but we do not wait for the albumin to improve to 3 or more because it may take more time. And there's no role of actually giving albumin in the preoperative period to improve overall albumin in the patient. So, and clinical markers of increased nutritional risk include a BMI less than 18.5, acute weight loss, 5% in 4 weeks and up to 10% in 6 months, actual body weight of less than 90% of ideal body weight, sarcopenia, and or pre-albumin levels if available. So it is reasonable to consider delaying surgery until nutritional deficit is corrected if it is feasible. Now, there are a lot of tools available for screening for malnutrition. So we have a malnutrition universal screening tool or MUST, nutritional risk screening. Then we have subjective global assessment and traditional anthropometric measurements like body weight, serum, nutritional factors, skin fold thickness, and functional measurement. So these are the details. So malnutrition universal screening tool basically is a screening tool, and it is easy, inexpensive, but it focuses on BMI and can mask nutritional risk in overweight patients. Then malnutrition screening tool is also easy, completed by any trained member of the multidisciplinary team. Minimal training is required, but it doesn't consider the future changes. A commonly used tool is a subjective global assessment tool. It has series of subjective questions to assess change in weight, appetite, functional capacity, and current symptoms. It is sensitive to even small changes in the short period of time and designed for oncology patients specifically, and considered gold standard for cancer patients. The problem is that it is long, it requires well-trained and skilled professionals who can interpret it and exclude patients who are unable to complete. So we do use SGA, but in project mode in select patients for which we have some thesis or some project going on for assessment of nutrition. So SGA categorizes it as A, B, C. A is well-nourished and C is severely malnourished. NRS will categorize as patient score 1, patients are admitted to hospital because of complications, and score 3 will be patients in the intensive care with assisted ventilation. And similarly, NRI, basically more than 97.5% are well nourished and less than 83.5 score is severely malnourished. So it will have a score based on serum albumin, current weight by actual weight, and these are the formula for that. So important thing is, so once we decide, we know that patient will be malnourished mostly. So now how to give the supplementation of nutrition. So we give IV, we give total parenteral, or we give enteral. So as far as possible, it is a good strategy to give an enteral nutrition because it will improve the immune function, maintain GI barrier, promote portal circulation, and stimulate hormonal secretions. Peripheral parenteral or parenteral may be considered if it is not possible to give enteral through the enteral route, whether we give oral for that. And because there are a lot of issues associated with IV-based nutrition, and that needs to be avoided. So in very, very few patients in our practice also, we end up giving total parenteral if it is not possible to give enterally, and we usually give it for about a week. And that is, say, 1 or 2 patients in a year. So that is hardly practiced because of associated problems. Now, as I said, nutritional prehabilitation is important component of prehabilitation. So ESPN recommends protein intake of up to 1.2 to 1.5 per kilogram ideal body weight in a day in 3 divided meals, supplemented with whey protein in powder form. So usually 10 to 30 grams per day. Whey protein, 4 weeks of preoperative colorectal cancer patients. So it has improved bioavailability with anti-inflammatory and immune modulating properties, and also contains the essential amino acids. Now, carbohydrate loading has been now discussed in detail in most of the platforms. Prior to elective surgery, it promotes maximum glycogen storage and decreases the peripheral insulin resistance. Now, there is a synergistic action of nutrition with physical exercise therapy. Up to 30 grams of protein immediately after resistance training improves muscle protein synthesis and optimizes the utilization of nutrients, and overall helps the patient to complete the exercise training. So we have to ensure there is a nutritional prehabilitation going on along with exercise training. Now, this was a pilot study published in 2014, and they showed that nutritional counseling with whey protein improved overall 6-minute walk test from baseline to surgery as compared to only nutritional counseling with placebo without the whey protein. Now, preoperative nutritional state is important. So elective abdominal surgery, nutritional scoring was used. So the complication rate was much more in patients with no preoperative nutrition as compared to those who received preoperative nutrition. So take-home point is that the control group had significantly higher number of serious post-operative complications. So control group was those patients who did not receive preoperative nutritional support. So it is important that we start nutritional support in the preoperative period for non-malnourished patient as well, as it helps to improve the overall status of the patient and reduce the post-operative complications. Now, a word about immunonutrition. It is basically nutrients which refers to routine supplementation of specific nutrients, even if they are adequately nourished patients. Now, current recommendations suggest that supplementation even for 7 days preoperatively for all major elective surgeries, but dosage is not very clear. So the common used immunonutrition is glutamine, arginine, and omega-3 fatty acids. Glutamine tends to preserve small bowel function. Arginine stimulates T cell function and improves microcirculation via nitric oxide formation. And omega-3 fatty acid has anabolic and immune modulator function. So if you administer prior to GI surgery, they may specifically thought to reduce wound infections and reduce the length of stay. Now, this was an interesting study published in 2009, and they showed that EPA supplemented early enteral nutrition was associated with preserved lean body mass post-esophagectomy compared to standard enteral nutrition. These properties may merit longer study to address its impact. So, icosapentaenoic acid-based nutrition had overall improved the lean body mass of the patient. Now, another component is anxiety. All of us know a lot of psychological issues are there in these patients, so which may lead to anxiety, distress, depression, which in turn may lead to immune dysregulation, impaired wound healing, more pain in the post-operative period, as pain has a lot of psychosocial component, prolonged recovery, and a poor quality of life. So we need to prepare these patients psychologically as well. And the methods, we know we have deep breathing, relaxation, yoga therapy, and music therapy. So important thing is it has to be done by a trained psychologist. It also enhances and reinforces motivation of the patient to comply with the exercise, and they tend to be happy, and they also take care of the nutrition better if a good exercise method for anxiety reduction is done. Optimal duration we have discussed. This is a table which shows the components, what is the intervention we do and what is the optimal period. So for nutrition, we need about 2 to 6 weeks. Anxiety, basically relaxation technique and problem solving, so up to 2 weeks might do. For respiratory and cardiovascular, you may need 6 to 8 weeks. And for anemia correction, depending on the therapy you use, usually it is 1 gram per week, depending on the method we use. Parenteral is preferred, as I said, usually IV. So this is the usually time frame for improvement. So as little as 1 to 2 weeks might be good for improvement if we initiated in time. The most important thing in prehabilitation is not about starting a protocol, but ensuring patients adhere to it. So we can have standard instructional booklets, so written in easy comprehensible language. They should be figures, pictures, which will describe the importance of all the elements in detail. Also, there should be a diary where patient can record whatever activity he or she is doing. And in addition, one of the team members should be contacting the patients by telephone to maintain what is the compliance frequency, intensity, or duration of exercise. Now, how do we measure the success of prehabilitation? All of us know that the cancer surgery is not about doing surgery. Cancer management is about completion of the oncology treatment. So it includes surgery, good surgery, good radiotherapy, and good chemotherapy. So all the 3 arms of the cancer treatment have to be completed for a good outcome in the long term. So return to intended oncology treatment is a good metrics to measure, which in turn suggests that whatever patient is planned for completing the oncology treatment, how much of them are able to complete the oncological treatment is a good measure of success of prehabilitation outcome. Days alive, out of hospital at 90 days, other like patient satisfaction, complications, hospital length of stay, and overall access is important. Now, goals and benefits of cancer prehabilitation. So pre-treatment baseline. So we need to see that treatment-related impairments are reduced, unnecessary testing is reduced, time to recovery milestones is reduced, the risk of recurrence, future comorbidities, hospital readmissions are reduced, overall psychosocial health outcomes are improved, occupational function is improved, time to return to work is reduced. So overall, all the parameters which are important for a patient improve, and so it should be done. So what are the barriers? So we know it is good. We know what is the optimum time we should do. We know the measures which are very simple, which we can do actually at home. But still, the compliance and the implementation is not up to the mark. So what are the barriers? The barriers are compliance of the patient. Patient come to the hospital from far off places. So people will come throughout the country to select cancer centers. So transportation is an issue. There is a cost to it, cost of transportation and staying near the cancer center. And sometimes the cancer treatment is more crucial. So as I discussed earlier, so the window of opportunity for prehabilitation is less. And so it may not be as effective. So home-based prehabilitation with supervision is the key, and that should be implemented. A word about ERAS. So I'm sure there will be a lecture, so I'll be just touching about it. So ERAS is a component of preoperative, intraoperative, and postoperative interventions which attend to improve and enhance recovery from surgery and anesthesia after a major surgical procedure. And prehabilitation is an important component of it. It complements ERAS and promotes early return to baseline functional capacity and overall improve the timely return to post-operative adjuvant cancer therapies. So these are the components. I'll not go into detail, and prehabilitation is an important component of ERAS. And these are the common things which in common cancer. So in lung cancer, smoking cessation and breathing exercises, head and neck cancer, cervical range of motion and swallowing exercises, prostate cancer, pelvic floor exercises, and for breast cancer, shoulder and cervical range of motion exercise and upper body strengthening. So depending on the surgery, depending on the patient's condition, the exercises can be taught to the patient. This is probably repetition. So does the location of prehabilitation services delivery matter? So it should be within the oncology center, within the rehabilitation medicine department, on-site but different department, within the hospital but under the oncology, or community-based. So the farther the patient is from the core team of management, be it surgeon, anesthesiologist, palliative care physician, radiation oncologist, or medical oncologist, the less controlled physician has the care over the care delivery. So it is important that it has to be in-housed in the department where the patient is being taken care of. And it is not a good idea to outsource to other departments because it will be really difficult to control and monitor the patients closely. Limitation, as we discussed, time, compliance, we need a good team, associated cost, and adherence. So these are the limitations of prehabilitation. So we again come back to the same question, that prehabilitation versus rehabilitation. So we can see that 6-minute Watt test improved better with prehabilitation as compared to rehabilitation. Rehabilitation exercise prior to surgery or treatment in lung cancer improved functional capacity significantly before surgery, reduced post-operative morbidity and in-hospital stay. Patient initially considered inoperable due to cardiopulmonary impairment may become candidate for potential curative surgery if we do a good preconditioning of the patient. Now this I'll skip. So components of quality of life is also important when assessing these patients. So we need to see improved survival can be done by surgery, radiotherapy, chemotherapy. So these overall things improve the survival. But suppose the patient is not amenable to surgery, so we need to improve the quality of life. So we need to have psychosocial rehabilitation programs, other integrative therapies, and palliative care. So this has to be kept in mind to give a comprehensive care of the patient. So the take-home message is that anemia, malnutrition, smoking, and alcohol use are modifiable risk factors that should be identified in time of diagnosis of malignancy, and appropriate action should be taken. CPET is a gold standard for quantification of functional capacity of the patient, risk stratification, and to guide rehabilitation programs. Early dietitian involvement in malnourished patient is important and should be done. Multimodal prehabilitation programs complement enhanced recovery programs and expedite the post-operative recovery of functional capacity, reduce complication, and reduce commencement delays in adjuvant therapy, and overall improve the outcome of the patients. So whenever feasible, whatever time feasible, whatever mode is possible, whether we can do nutritional, exercise, psychosocial, anemia management. So all these things should be done, and they definitely improve outcomes of the patient. So prehabilitation and rehabilitation overall improves the quality of life. And this is the overall umbrella of quality of life, which is the more important metrics. So patient-reported outcomes are the key parameters nowadays to monitor. And if a good prehabilitation along with rehabilitation is done, the patient-reported outcomes are much better if they are not done. So this will leave. This again, I come to this slide which I showed earlier. So it is a continuum of care from the perioperative period, and the post-operative period. And we start from prehabilitation, enhanced recovery, and rehabilitation. All the three components are as important. So it is like training for a marathon, then 48 to 72 hours before, during and after the race, and then recovery and training for the next marathon. So this is a complete continuum of care and should be done diligently. Now, future perspective, more and more better studies on cancer rehabilitation are coming up, and they are further reinforcing the importance. Well, increase in oncologists wanting rehabilitation care. Nowadays, I have a request coming from the surgeons, the medical oncologists, to improve overall condition of the patient. It is a part of bundle of care and should be thought of, and it should not be optional. So there is no option of starting rehabilitation, and it should be a standard of care for cancer patients. So prehabilitation improves outcomes for oncology patients. So if there are some students, there are some questions which might help them in the exam. So, okay. So this is the last slide. So I can take questions if there are any.
So thank you, Dr. Nishkarsh, for a wonderful talk on prehab part, and you covered almost everything which is required for a good outcome after cancer surgeries, especially the major abdominal and the thoracic surgeries. So like prehab will be there, and it should progress only. It will not go anywhere. It will go further and further in long run. So I invite, if anybody wants to ask any question. Is there any question on the chat box? I'm not able to see any question on the chat box.
Yes, sir. I'm providing the questions on the chat box.
Yeah.
Dr. Nishkarsh, while we're waiting for those questions, can I ask one question?
Please, ma'am.
Yeah. So what do you think about the role of ferrous carboxy maltose you spoke about? So with what frequency do you administer it? How often? So
usually it is a single dose, because we usually have 2 to 3 weeks, and we if we give a total dose iron therapy, that usually improves 1 to 2 gram over a period of 2 to 3 weeks.
Okay. And the other thing I wanted to ask is, as far as CPET goes, is there any particular group of patients, meaning related to the disease itself or to the type of surgery that is being performed, in which CPET is shown to be of particular benefit?
CPET will be beneficial to most, but with my experience is limited to the thesis and projects we do, because it takes some time before the CPET. Usually takes about an hour, you get a report, and then you have to do it at frequent intervals. So we have done mostly in patients of breast and patients with mostly in CA breast patients, and we found it improved.
Okay.
The only challenge with CPET is that patient should be fit enough to do it. So you cannot do it in each and every patient. So if the patient is cachexic, fatigued, he's not able, he's barely able to walk. So those patients are not fit for doing CPET. So in those patients, 6-minute walk test can be a good surrogate measure to assess the need and the effectiveness of intervention, whatever we may do.
Yeah. And the other thing I wanted to ask is, you mentioned immunonutrition. What about the cost of immunonutrition? Is it prohibitive?
So I covered it because of completion's sake. To be honest, we are not using it as a routine for two reasons. There is a cost to it, and secondly, off late the data is not very supportive of any benefit of their use. So, but yes, if it is feasible, patient can afford, we can give. It might help, but there is no clear-cut evidence as of now.
So mostly it is basically based.
About the hello.
Yeah,
so about that immunonutrition point of view, I'm just saying, because we tried in a few patients, and because they were just on some experimental, something gifted from, so we tried in some very few patients, but there is no evidence of any good outcomes or something like that. But and it is very costly to prescribe immunization to any patient, especially in India, without any benefit. So until we have good studies like having outcomes of we really should not for immunization. But what do you think, Dr. Nishkarsh, right?
Yeah, because I think it just keeps coming up every decade. Immunonutrition keeps coming up.
And the company is kind of pushing for it. So you might get a 1 or 2 study which supports, then they tend to push for the product. But mostly we have not found with any benefit, and we are not using routinely as well.
Okay. What about globulin? Is there any supportive evidence for globulin? I mean, people tend to focus on albumin, but before you joined, we were discussing this, and Dr. Sohan said that globulin is something that we need to focus on as well.
My experience is limited. So, but yes, we can see that because pre-albumin, there are some studies, but I'm not sure whether globulin, as of now, literature is there. But yes, we can use, we can try have a study. Why not? And see how, because that is also being measured along with albumin mostly. So we need to see.
Sohan, do you want to add anything to that globulin question? I think Sohan's phone it was not very well charged. I also wanted to ask one thing. So basically it's patient motivation that you are focusing on, right? And following them up. So basically a prehabilitation program depends upon the monitoring that you do and...
yes, ma'am. So mostly, as I said, it is not a standard of care as of now, but yes, we do a lot of projects and thesis for students. And as a part of thesis, we do follow them regularly. So as I said in my presentation as well, so the most problematic thing is the monitoring. So we can always start the program, but you need somebody to follow them regularly and ensure that it is being complied for. So that has to be ensured. Even a nursing staff can be a good option to follow this up, but we need somebody to do it diligently.
So basically the manpower required is significant. That is what you're saying.
It is not significant, but you need somebody to do it dedicatedly. So
dedication is required, yeah.
So it is, you don't need too many people. You need one person to advise, then physiotherapists can explain them, or if they're doing a CPET guided, they can do that. But you have to monitor that they're doing it continuously. So that is important. So one person can follow, say 20, 30, one person can easily follow 20, 30 patients, but somebody has to do it.
So the program has to be in place for an institution.
It has to be integrated program with dedicated people doing it.
Thank you very much for a very lucid talk. I don't know whether Sohan has joined back. Sohan, do you want to say anything?
I'm here. Yeah.
Anjali ma'am, shall I post the questions in the chat? One question
yes,
I already
please,
posted.
yes, please. Yeah, can you read it out?
Yeah.
So this is not a question. So Shikhar More was our resident. So he was one of the first ones who did thesis on CPET. So we are one of the early institutes to have CPET in our system, and we had tried to use it for at least high-risk surgeries and high-risk patients and some patients who are part of thesis. So he's just suggesting that fully integrated in department. So he's written that. There's no question in that. Thank you, Shikhar.
So that was a remark. Okay. So thank you very much.
Dr.
Vibha has said something. What does she say?
So ma'am is also suggesting they are doing so. Sohan is here, so I will take this opportunity. Sohan, we should have a dedicated component bundle of care of a prehabilitation which is feasible in our country, and we should follow it up and see how good it is and what are the things we can do. It's high time we should have one, maybe multi-center.
Yeah. Actually, you are right. We should have like a prehab bundle type things we can plan and they say like these are the like at least some minimal mandatory prehab bundle that we can formulate from SOPSI, and it will be good to have such type of things.
Yes.
We can definitely work on that, and we can come out soon. And
yes,
it won't take much time also.
Sure.
I think Dr. Rashmi from Bangalore has posted a comment saying, would the surgeons be ready to wait for prehab? So I think
my answer will be yes. If they know it is good, it is yes. So what we did at IRCH it was initially a program more for a project. So thesis, if you do, you can't say no, they will eventually do it. But over a time, they will realize the importance of it. And so once they realize, they will send us referrals 2 weeks before, just see the patient, improve nutrition, improve overall exercise capacity. So now we have started getting those also. So you have to be persistent and show the benefit.
So surgeon will definitely say yes for prehab because their patients are getting benefited, right? It is mainly the patient come on the surgeon's name, and the patient is getting better, so they will be happy to apart from patient. So the surgeon will definitely say yes if we show them the good outcome, right?
Yeah, I think also it depends on the type of disease, right? As Dr. Nishkarsh had put up a slide about that. How urgent is the surgery? So definitely if you have time, maybe, you get much better outcomes.
Ma'am, mostly we have at least 2 weeks. Someone will agree with me. Even the corporate setup, you have 2 weeks at least, and that is not a bad time to start for. So if in 2 weeks also we can do something good for the patient, which may improve outcomes.
Yeah, even some interventions like stopping smoking and all those things, I think correction of anemia gives very good results because it is an independent predictor of mortality. I think this correction of anemia itself will give good results. But yeah, I understand Dr. Rashmi's point as well that the surgeons need to be on board. They need to understand.
So whether it is ERAS or prehabilitation, it is a multidisciplinary thing. We cannot take a call on ourselves.
Sorry to say, actually, my phone is getting done. I want to take leave. Dr. Anjali, please continue with the discussion.
Thank you so much.
Thank you. Thank you all.
Yeah. Thank you.
Thank you. Okay, so do we have any other questions in the chat box? I cannot see any more.
No, ma'am, there are no more questions or any comments.
Okay. So I'd like to thank Dr. Nishkarsh for a very lucid representation of what prehabilitation means for us and the role of CPET. Thank you so much. You did it at a very short notice. And remember that next time we're going to discuss journal reviews. The purpose of that is that we're going to start some sessions on journal reviews. So Dr. Devatya is going to discuss how to perform a journal review in the first place. Okay. With that, I think we can sign off.
Thank you. Thank you, Dr. Anjali, for the invite.
Thanks.
Thank you.
Thank you, ma'am. And thank you, sir. Thank you so much for all your presence. With that note, we are concluding the session here. Thank you all for giving us your precious time.
Good evening, everyone. Bye.
Bye.